So children, today we'll be starting with chapter 35 of Apurba Sastry Essentials of Microbiology, which is Malaria and Babesiosis. In the part 1 of the video, we'll be covering the history, agent, life cycle, pathogenesis and epidemiology of malaria, while in the next part we'll be covering the lab diagnosis of malaria and some details about babesiosis. So starting with malaria. History. Malaria is one of the oldest documented diseases of mankind. The name malaria, mal means bad and area means air, was derived from the ancient false belief that the disease spreads by air pollution through stagnant water and marshy lands. Sir Alphonse Laveran in 1902 and Sir Ronald Ross in 1907 won the Nobel Prize for their contributions in malaria. Alphonse Laveran, 1880, was the first to discover the causative agent Plasmodium in the red blood cell RBC of patient in Algeria. Sir Ronald Ross in 1897 had described the sexual cycle of parasites in female Anopheles mosquito in Secunderabad, India. Mr. Tu Youyou, a chemist, was awarded Nobel Prize 2015 for the discovery of artemisinin, which is used for the treatment of falciparum malaria. Agent. Although several species of Plasmodium exist infecting a range of birds, reptiles and mammals, human infection is mainly caused by 5 species. Plasmodium vivax causes benign tertiary malaria. Periodicity of fever is once in 48 hours, that is recurs every third day. Plasmodium falciparum causes malignant terranean malaria. Severity of malaria, periodicity of fever is 1 in 48 hours, recurs every third day. Plasmodium malariae causes benign quartron malaria. Periodicity of fever is 172 hours, that is recurs every 4th day. Plasmodium ovale causes ovale terrain malaria. Periodicity of fever is once in 48 hours, that is recurs every 3rd day. Plasmodium novellesi causes quotidian or simian malaria. Fever periodicity is once in 24 hours, that is recurs every 3rd day. It is a parasite of monkey but can also infect humans and many cases affecting man was recently reported from Asia. Life cycle. Host. Plasmodium completes the life cycle in 2 hosts. Definitive host, female Anopheles mosquito, sexual cycle or sporogamy takes place, and intermediate host, man, asexual cycle or schizogamy takes place. Male Anopheles do not feed on man and feeds exclusively on fruit juice. That is why male Anopheles mosquito does not transmit the disease, whereas female Anopheles needs at least 2 blood meals before laying eggs. Although several species of Anopheles can transmit the vectors of primary importance include Anopheles cruciferis in rural areas, Anopheles stephensi in urban areas, and Anopheles fluviatilis in hilly areas. Human cycle. Mode of transmission and infective form. Man acquires infection by the bite of female Anopheles mosquito. Sporozoids infective from the salivary gland of mosquito are directly introduced into the cutaneous venules and enter the blood circulation. Rarely it can also be transmitted by blood transfusion or transplacental transmission. Here, trophozoites or merozoites act as the infective form. In humans, the asexual cycle takes place through 3 stages: pre-erythrocytic schizogamy, erythrocytic schizogamy, and gametogamy. Pre-erythrocytic or hepatic stage. Sporozoids leave the circulation within 30 minutes and infect the liver. This stage occurs in the liver and is so named because it occurs before the invasion of RBC. It is also called exoerythrocytic stage or interhepatic or tissue stage. The motile sporozoids leave the circulation within 30 minutes and enter the liver. Attachment. The circumsporozoid proteins present on the surface of sporozoid bind to the receptors present on the surface of hepatocytes, facilitating the entry of sporozoids. Trophozoites. After entering into the hepatocytes, the spindle-shaped sporozoids become rounded and transform into trophozoites. Schizogamy. Trophozoite is the feeding stage of the parasite which later on undergoes several nuclear divisions and transforms into a physiological schizont. We'll see the figure in a short while. The pre-erythrocytic schizont contains several merozoites released outside on rupture of hepatocyte. Merozoites then attack RBCs to initiate erythrocytic stage. No liver injury. As only few hepatocytes are infected by Plasmodium, so hepatic damage does not occur in malaria. Duration of pre-erythrocytic schizogamy varies from 5 days to 15 days depending on the species. Hypnozoids. Some sporozoites of Plasmodium vivax and Plasmodium ovale do not develop further and may remain in liver as hypnozoids and cause relapse of malaria after many years. Relapse should be differentiated from other phenomena seen in Plasmodium falciparum and Plasmodium malariae called as recrudescence. Erythrocytic schizogamy. Hepatic merozoites, after entering into bloodstream, infect the RBCs. The hepatic merozoites, after release from pre-erythrocytic schizons, attack the RBCs. The merozoites bind to glycophorin receptors on RBC surface, enter by endocytosis, and are contained within a parasitophorous vacuole inside the RBCs. Trophozoite. Soon the hepatic merozoites transform into trophozoites. Early trophozoites are called as ring forms, which are annular or signet ring in appearance and contain a central vacuole with a peripheral thin rim of cytoplasm and a nucleus. Late trophozoite ring form enlarges and becomes more irregular and transforms into late trophozoite or amoeboid form. Malarial pigment. Plasmodium feeds on hemoglobin, releasing the undigested products hematine and iron porphyrin, which combine to form malarial pigment, hemozoin pigment. Schizogamy. Later, trophozoite undergoes schizogamy to produce 6 to 30 daughter merozoites arranged in the form of a rosette. This form is known as erythrocytic schizont. RBCs then rupture to release the daughter merozoites, malarial pigments, and toxins into the circulation, which result in the paroxysm of fever at the end of each erythrocytic cycle. Each merozoite is potentially capable of invading a new RBC and repeating the cycle. Intra-erythrocytic life cycle takes 48 to 72 hours depending upon the species. About 48 hours in Plasmodium vivax, Plasmodium falciparum and Plasmodium ovale, and 72 hours in Plasmodium malariae. In Plasmodium falciparum infection, the latter stages of erythrocytic cycle occur in the capillaries of brain and internal organs. Hence, only the ring forms are found in peripheral blood examination but not late trophozoites and schizons. Gametogamy. After a series of erythrocytic cycles, some merozoites, after entering into the RBCs, instead of developing into trophozoites, they transform into sexual forms called as gametocytes. The gametocytes are usually found round in shape except in Plasmodium falciparum, in which they are crescent or banana shaped. They are of two types, male gametocyte or microgametocyte and female gametocyte or macrogametocyte. Gametocytes neither cause any clinical illness nor they divide but play an important role in the transmission of disease. Gametocytes are the infected form to mosquito. They are capable of transmission only when they are mature, viable, and present in sufficient density. 12 gametocytes per cubic mm of blood to infect mosquitoes. The mosquito cycle. A female Anopheles mosquito during the blood meal takes both asexual and sexual forms. The asexual forms digested, whereas the asexual forms get digested, whereas the sexual forms, that is gametocytes, undergo further development. Each male gametocyte undergoes X-flagellation and divides into 8 flagellated actively motile bodies called as male gametes or microgametes. Female gametocyte does not undergo X-flagellation but directly develop into one female gamete or macrogamete. Zygote. The male gamete fertilizes the female gamete, which forms a zygote. Eukinete. Zygote transforms into a motile elongated form called as eukinete in the midgut. Oocyst. The eukinete penetrates the stomach wall of the mosquito and becomes rounded, covered by a thin elastic membrane to form oocyst. Sporozoites. Each oocyst undergoes sporogony meiosis to produce 4 spindle-shaped sporozoites. On rupture of mature oocyst, the sporozoites are released and migrate to salivary gland and the cycle is repeated. Extrinsic incubation period. Time required to complete the life cycle in mosquito varies from 1 to 4 weeks depending upon the species. The differences in the life cycle of mosquitoes of the four species are depicted in the table. Plasmodium knowlesi has been discovered recently and therefore discussed separately. Okay. Plasmodium knowlesi. It is a malaria parasite of monkeys but can also rarely affect humans. Anopheles leucospirus is the main vector. Epidemiology. The first human case was documented in 1965. However, cases in humans increasingly have been on a rise, reported from Asia since 2008. World. Maximum cases have been reported from Malaysia, highest Thailand and Myanmar. The largest foci are located at Malaysian Borneo. 3122 cases have been reported between 2004 to 2015. India. The only report of Plasmodium novelsi infection has been documented from the Andamans. However, India has all the potential of getting cases as the vector is found in the coastal regions of Kerala and Maharashtra. Clinical features. Plasmodium novelsi produces an acute illness and relatively high parasitemia. Paroxysm of fever occur daily. Quinotidian malaria because of short RBC cycle 24 hours. Clinically, it resembles Plasmodium vivax, but severe malaria is seen more frequently, 7 to 10%, compared to 3% of Plasmodium vivax. However, it infects RBC of all ages. Common complications seen are respiratory distress, most frequent, and renal failure. No cerebral malaria has been reported so far. Lab diagnosis. On blood smear examination, early trophozoite of Plasmodium novelsi is distinguishable from Plasmodium falciparum. Sometimes shows multiple ring forms, acole forms, and double dot ring forms. The late trophozoites with band forms and round gametocytes are morphologically similar to that of Plasmodium malariae. Currently, no specific rapid diagnostic test (RDTs) are available to detect Plasmodium novelsi. Plasmodium novelsi specific nested PCR assays are available using the primers PMK8 and PMKR9 targeting small subunit rRNA. Treatment. It responds well to chloroquine or primaquine. As the disease rapidly progresses, treatment should be promptly started. Now we see the figure and the tables which we have left. So let's come to the figure. In this figure, it has shown all the stages of malaria parasite. So starting with the sporozoites in salivary glands of mosquito are injected into the human by the bite of the mosquito. Now these sporozoites of all species, they enter the hepatocyte and the sporozoite transforms into trophozoite, which transforms into pre-erythrocytic schizont and which transforms into hepatic merozoites, which are released into the blood. In species of Plasmodium vivax and Plasmodium ovale, some sporozoites may become latent to form hypnozoite, which accounts for the relapse of malaria after many years. Now these hepatic merozoites affect the RBCs and enter the RBC membrane. They form the ring form, late trophozoite, immature schizont and mature schizont stage to release more erythrocytic merozoites. Now either these erythrocytic merozoites can enter the other RBCs and infect them, or they can form the gametes. The gametocytes of Plasmodium vivax and ovale and malaria appear round, while Plasmodium falciparum has spindle-shaped gametes. Now these gametocytes are transmitted into the mosquito. In the stomach of mosquito, the macro and microgamete fuse to form the zygote, which forms the oocyte and oocyst. The mature oocyst with sporozoites enter the salivary gland, from where it can affect the other human host. The relapse and recurrence in malaria. The relapse means is seen in Plasmodium vivax and Plasmodium ovale, while recrudescence is seen in all species but more common in Plasmodium falciparum, followed by Plasmodium malariae. In relapse, few sporozoites do not develop into pre-erythrocytic schizont but remain dormant, known as hypnozoites, for 3 weeks to 1 year. In falciparum malaria, recrudescence is due to the persistence of drug-resistant parasites even after completion of the treatment. Reactivation of hypnozoites leads to initiation of erythrocytic cycle and relapse of malaria. In Plasmodium malaria infection, long-term recurrences are seen for as long as 60 years. This is due to long-term survival of erythrocytic stages at a low undetectable level in blood. Concept of strategy exo or pre-erythrocytic stage. Formerly, it was postulated that relapse occurs due to secondary exo or pre-erythrocytic stage, where a proportion of hepatic merozoites released from pre-erythrocytic schizon again attack the liver cells. But now it is believed that secondary pre-erythrocytic stage does not occur and relapse occurs due to sporozoites undergoing dormancy during the primary pre-erythrocytic stage. Okay, now we see the differences between the four malaria species. The release seen in Plasmodium vivax, not seen in Plasmodium falciparum and Malaria, seen in Plasmodium ovale. Recrudescence, not seen in vivax, seen in falciparum and Malaria, not seen in ovale. Erythrocytic stage, 48 hours in vivax, 36 to 48 hours in falciparum, 72 hours in Malaria, and 48 hours in ovale. Pre-patent period, 8 days in vivax, 5 days in falciparum, 13 days in Malaria, and 9 days in ovale. Incubation period, 14 days in vivax, 12 days in falciparum, 28 days in malaria, and 17 days in ovale. RG interval, 4 to 5 days in vivax, 10 to 12 days in falciparum, 11 to 14 days in malaria, 5 to 6 days in ovale. Extrinsic IP, 8 to 10 days in vivax, 9 to 10 days in falciparum, 25 to 28 days in malaria, and 14 to 16 days in plasmodium ovale. Now this completes our life cycle and we start with pathogenesis and clinical features of malaria. First comes the benign malaria. Benign malaria is milder in nature and can be caused by all four species. It is characterized by triad of febrile paroxysm, anemia and splenomegaly. Febrile paroxysm. Fever comes intermittently depending on the species. It occurs every fourth day, 72-hour cycle for Plasmodium malariae and every third day, 48-hour cycle for other three species. Paroxysm corresponds to the release of successive broods of merozoites into the bloodstream at the end of RBC cycle. Each paroxysm of fever is comprised of three stages. Cold stage lasts for 15 minutes to 1 hour. The patient feels lassitude, headache, nausea, intense cold, chills and rigor. Hot stage. Patient develops a high-grade fever of 39 to 41 degrees Celsius and dry burning skin. Headache persists but nausea diminishes. Sweating stage. Fever comes down with profuse sweating. The skin becomes cold and moist. Patient feels relief and often asleep. This stage lasts for 2 to 4 hours. The classical paroxysm may not be present always due to the maturation of generations of parasite at different times. In Plasmodium falciparum, the fever is more irregular or even continuous with marked prostration, headache, and nausea. Anemia. Patient develops normocytic normochromic anemia, which may be attributed to various factors. Parasite induced RBC destruction. Lysis of RBC due to release of merozoites. Splenic removal of both infected RBC and uninfected RBC coated with immune complexes. Bone marrow suppression leading to decreased RBC production. Splenomegaly. After a few weeks of febrile paroxysm, spleen gets enlarged and becomes palpable. Splenomegaly is due to massive proliferation of macrophages that engulf parasitized and non-parasitized coated RBCs. Falciparum malaria, the malignant tertine malaria. Pathogenesis of Plasmodium falciparum is different from other species. Sequestration of parasites. An important feature of pathogenesis of Plasmodium falciparum is its ability to sequester or hold back the parasites in the blood vessels of deep visceral organs like brain, kidney, etc. This leads to blockage of vessels, congestion and hypoxia of internal organs. Sequestration is mediated by cytoadherence. It refers to the binding of infected erythrocytes to endothelial cells. It is mediated by a specialized antigen called as Plasmodium falciparum erythrocyte membrane protein 1 (PFEMP1), which binds to specific receptors present on the vascular endothelium of deep organs. PFEMP1 also helps in binding of infected RBCs to uninfected RBCs by a process called rosetting. Since the parasites are sequestered back in the vessels, they can avoid the frequent spleen passage, hence can escape splenic clearance. PFEMP undergoes frequent antigenic variation, thus helps the parasite in evading the host immune response. Complications. Complications of falciparum malaria. Plasmodium falciparum infection is more acute and severe in nature with more complication than benign malaria. Cerebral malaria. This is the most serious complication seen in falciparum malaria. Its results due to plugging of brain capillaries by sequestered parasites RBCs leading to vascular occlusion and cerebral anoxia. Pernicious malaria. It is characterized by black water fever, algid malaria, and septicemic malaria. Black water fever. This syndrome is characterized by sudden intravascular hemolysis followed by fever, hemoglobinuria, and dark urine. It occurs following quinine treatment to subjects previously infected with Plasmodium falciparum. Autoimmune mechanisms. Antibodies develop against parasitized and quininized RBCs with subsequent infection and quinine treatment. This immunocomplex formation followed by complement mediated massive destruction of both parasitized and non-parasitized RBCs. Algid malaria, characterized by cold, clammy skin, hypotension, peripheral circulatory failure, and profound shock. Septicemic malaria, characterized by high-grade fever with the dissemination of parasite into various organs, leading to multi-organ failure. Pulmonary edema and adult respiratory distress syndrome. Severe falciparum malaria in adults may lead to non-cardiogenic pulmonary edema, often aggravated by overhydration. It does not usually respond to anti-malarial therapy. Mortality rate is more than 80%. Hypoglycemia is associated with a poor prognosis and particularly problematic in children and pregnant women and following quinine therapy. Renal failure. It occurs due to the erythrocyte sequestration in renal microvasculature leading to the acute tubular necrosis. It is common among adults than children. Bleeding, disseminated intravascular coagulation. Patient presents with significant bleeding and hemorrhages from the gums, nose, and intestine with or without evidence of disseminated intravascular coagulation. Severe jaundice. More common among adults than children, it results from hemolysis, hepatocyte injury, and cholestasis. Severe normochromic normocytic anemia, characterized by hematocrit of less than 15% or hemoglobin level of less than 5 gram per deciliter with parasitemia level of more than 10 to the power 5 per microliter, more than 2%. Acidosis results from the accumulation of organic acids like the lactic acids. Chronic complications of malaria. Tropical splenomegaly syndrome, it is also called as hyperactive malarial splenomegaly, occurs in malaria endemic areas of tropical Africa and Asia, including India. It results from an abnormal immunologic response to repeated malaria infections and is characterized by elevated IgM due to polyclonal Bt cell activation and massive splenomegaly. Patients respond well to antimalarial chemoprophylaxis proguanil. Quartan malarial nephropathy. It is chronic complications seen with Plasmodium malariae, rarely Plasmodium novelsii and other species. It occurs due to injury to renal glomeruli by the immune complexes, resulting in nephrotic syndrome. Promotes Burkitt's lymphoma. Malaria-induced severe immunosuppression in African children provoke Epstein-Barr virus infection to develop Burkitt's lymphoma. Malaria in special situations. Transfusion malaria. Malaria can be transmitted by blood transfusion, needle stick injury, or organ transplantation. The clinical features and management of these cases are same as for naturally acquired infection mosquito-borne but differs in many other ways. The infected form of intraerythrocytic forms such as merozoite, trophozoite, or schizones but not gametocytes. There is no pre-erythrocytic stage of development and no relapse. The incubation period is often short. Clinical chemotherapy with primaquine is unnecessary and there is no relapse. Malaria in pregnancy. Malaria during pregnancy increases the risk of fetal distress and can result in premature labor, low birth weight, and stillbirth. In areas with high malaria transmission, pregnant women are particularly vulnerable to severe anemia, hypoglycemia, and acute pulmonary edema. Malaria in children. Nearly 1 million children die of falciparum malaria each year in endemic countries. Certain complications are relatively common among children like convulsions, coma, hypoglycemia, metabolic acidosis, and severe anemia, whereas other complications like jaundice, acute renal failure, and acute pulmonary edema are unusual in children. Immunity against malaria. Both innate and acquired immunity contribute to the resistance against malaria. This innate immunity. This refers to the inherent mechanism of host resistance against malaria parasite. This depends upon various factors. Age of RBCs, Plasmodium falciparum attacks RBC of any age. Plasmodium vivax and ovale attack the young RBC and reticulocytes, whereas Plasmodium malaria attacks the older RBCs. Nature of hemoglobin. Sickle cell disease, hemoglobin C and E, fetal hemoglobin and thalassemia hemoglobin are resistant to falciparum malaria. Hereditary ovalocytosis. In this condition, the rigid RBCs are resistant to falciparum malaria. G6PD deficiency type RBCs with G6PD deficiency are resistant to falciparum malaria. Duffy negative red blood cells, Duffy blood group antigens present on RBC membrane act as receptors for Plasmodium vivax. So people with Duffy negative RBCs, example West Africans, are resistant to vivax malaria. Age. Children are more prone to infection and complications. However, newborn are protected from falciparum malaria because of the high concentration of fetal hemoglobin in first few months of life. Nutritional status. As a paradoxical effect, severe malaria is rare in children suffering from malnutrition. Acquired immunity. Both cellular and humoral immunity contribute to the resistance against malaria. Humoral immunity. Circulating antibodies against asexual forms give protection by inhibiting the RBC invasion and sequestration, whereas antibodies against the sexual forms help in reducing the transmission of malaria. Cell-mediated immunity. It also plays a role in providing protection against malaria. Cytokines released from the T cells stimulate the macrophage and also stimulate B cells to produce antibodies. Premonition. An immunity against Plasmodium lasts till the original infection remains active, which prevents further infection. This is called as premonition or infection immunity or concomitant or incomplete immunity. Epidemiology of malaria. Malaria is the most lethal parasitic disease of humans, transmitted in 108 countries containing 3 billion people at least. Plasmodium falciparum predisposing factors. The transmission of malaria is directly proportional to density of the vector and the number of human bites per day per mosquito. Time of mosquito bite more often the dusk. Mosquito longevity, as porogamy lasts for 7 to 30 days. Thus, to transmit malaria, the mosquito must survive for more than 7 days. Optimum temperature 20 to 30 degrees Celsius, humidity 60%, and rainfall. Now, situation in the world according to 2018. In 2018, 228 million cases of malaria with about 4 lakh deaths occurred worldwide. Africa affected the worst, 93%, followed by Southeast Asia, including India. Now, globally, incidence rate. It is about 57 cases per 1,000 population at risk. Southeast Asia recorded the largest decline in 70% in incidence rate compared to 2010. Plasmodium falciparum is the most common species worldwide, accounting for 99.7% of malaria cases in African region, 50% in Southeast Asia. Globally, 53% of Plasmodium vivax burden in Southeast region, with 47% of vivax cases being reported from India. Plasmodium vivax is the predominant species in America, 75%. Malaria situation in India, NVBDCP report. According to National Vector-Borne Disease Control Program and BDCP, 3.3 lakh malaria cases were reported from India in 2019 with 73 deaths. Over the last decade, East Indian states such as Odisha, Chhattisgarh and Jharkhand have accounted for maximum malaria cases, Plasmodium falciparum being the predominant species. However, in 2018-19, Uttar Pradesh accounted for the largest malaria burden in India, where the majority of cases were due to Plasmodium vivax. Result, Plasmodium vivax became the most common species in India, more than 50%, followed by Plasmodium falciparum. Plasmodium malaria infections are less than 1% and reported time to time from various places such as Karnataka, Tumkur and Hassan district, largest foci, Chhattisgarh, Bastar area, Odisha, West Bengal, Madhya Pradesh, Tamil Nadu, Kerala and Assam. Plasmodium ovale is mainly confined to tropical Africa. Only few cases are reported from India such as Odisha, Koraput district, the first case of India, Chhattisgarh, Bastar area, Delhi, Assam, Gujarat and Kolkata. Malaria elimination in India. The malaria control in India has been operated through NVBDCP since 2006. WHO has initiated the Global Clinical Strategy, Technical Strategy for Malaria 2016-2030, which aims at elimination of malaria by the year 2030. Till date, 38 countries have already achieved the elimination status from WHO. In line with WHO NVBDCP, India has launched the National Framework for Malaria Elimination NFME in 2016, with vision of malaria elimination by 2030. All states, UTs of India are stratified into four categories based on annual parasite incidence API. Category 0, prevention of reestablishment phase. States or UTs with zero indigenous cases of malaria. Category 1, elimination phase. States UTs including the districts with API of less than 1 upon 1,000 population at risk. Category 2, pre-elimination phase. States or UTs with API less than 1 upon 1,000 population, but some of the districts are reporting API of more than 1 upon 1,000 population at risk. Category 3, intensified control phase. State or UTs with API of more than 1 upon 1,000 population risk. The objectives set for malaria elimination in India include elimination of malaria from all category 1 and 2 transmission states and union territories by 22. Interrupt indigenous transmission of malaria throughout the entire country including states, UTs and category 3 by 27. Prevention reintroduction of local transmission of malaria in areas where it has been eliminated and maintain national malaria free status by 2030 and beyond. Observation World Malaria Day. Every year 25th April is being celebrated as World Malaria Day. Anti-malarial month is celebrated every June. So this completes our part 1 of the chapter. Now in the next part we will be covering lab diagnosis and babesiosis. Okay, like, share, subscribe. Thanks for watching.